So, just as a quick recap, this is Health Students Taking Action Together. We're health professional students from all over the state of Georgia. Most of us here today are from Emory University and Morehouse University. We have nursing students, medical students, public health students. HealthSTAT itself actually also has PA students, physical therapy, business, law, theology students who are all here in support of patient care in Georgia. We are honored that you're here today to stop in, taking a moment, a very brief moment out of your very busy schedule to come speak with us. As you all know, and as I mentioned before, Governor Deal has been tasked with lots of very difficult decisions in his tenure here as governor. Currently, one of the main things on his plate, of course, that's coming from lots of national pressure and local pressure is Medicaid expansion. And he is here to just come and say hello to us. If you could just give us a few brief moments of why it's important to make the decisions that you make here at the Capitol, and what we as future professionals here in Georgia could do to help you make the tough decisions that you have to make every day.
Well, thank you very much. First of all, welcome to the Capitol. We're pleased that you would take time out of your schedules to come here. As you will gather in just a few minutes as you circulate around the building, this is a busy time in the General Assembly session as we are on the downhill side of the hump of the 40-day session. I think we've got, 16 days or something like that left. So these get to be rather hectic times as pieces of legislation that have moved through the committee processes and then go to full committees and then ultimately pass from one body to the other body, and the process starts all over again. It gets to be time becomes a precious commodity around here, so things get a little hectic. But thank you for what you have chosen to do, and that is to serve other people in the healthcare arena. This is going to continue to be one of the great areas of demand in terms of job opportunities, and I'm sure that was at least a small factor in your decision to choose this area. Everyone that predicts what the job markets of the future are going to look like always list healthcare and its allied industries as some of the areas that will continue to be of great demand. So it's important, as you may have heard me say on a couple of occasions, it's important that we educate our young people in the arena where they can get a job. We have not always had that kind of focus in the past, and much of the money that we put into our institutions of higher learning, unfortunately, sometimes have led to young people getting degrees and accumulating great student debt with degrees where they can't find a job. And that's a double tragedy, not only on the student but on their family as a general rule, because those loans will have to be repaid. But this is an area where I think you can have great comfort that your services into the future will be in great demand. I think what you will see too, and this has been a process that has been ongoing now for several decades. It used to be, in the early days of healthcare, that most of the things that were being delivered only by medical doctors. As that number of available physicians in relation to the population and the demands of that population got further and further out of balance, the requirements and the demands of the public were that people who were not simply medical doctors, those that were in allied professions that assisted medical doctors, be given greater authority to deal with healthcare issues. As Ben will tell you, those are issues that continue even until today. There are pieces of legislation that have been introduced this year that will expand the so-called scope of practice of various associated healthcare practitioners, and that will be an ongoing debate into the future. We have made progress, I think, in that direction. We want to always keep in mind that, of course, the highest quality of care is really the standard that we all want to adhere to. But sometimes availability is a factor that changes some of that. And our state is one that, unlike many other states, we have a huge portion of our population that is centered around the metropolitan Atlanta area. And as you get out into the more rural parts of our state, the availability not only of physicians, but many other services that we take for granted in a metropolitan area are simply either not there or you have to travel great distances to get those services. So in those areas in particular, I think you will continue to see the outreach of those who assist medical doctors being of greater demand. So I think you have great opportunities ahead of you. As was mentioned, we face an ongoing debate here in our state about how do we take care of our citizens. We are a state that has traditionally been regarded as, because of the economics of the way Medicaid works, we have what's called an FMAP rate. That is the federal matching rate with state money to support our Medicaid program. And the amount of money that the federal government puts into a state's Medicaid program is based on a number of factors, but it primarily is related to the economic level of the state. We have what would be considered a very favorable FMAP rate. It's almost a 2-to-1 federal money for state dollars. But nevertheless, even with that favorable rate, we came up upon a situation this year where we had about a $700 million shortfall in our Medicaid budget. One of the issues that had helped fill that shortfall in the past was a so-called provider fee that was being paid by hospitals. 1.45% of their net revenue was being paid to the state, that was then being used to leverage, on the part of the state, leverage an additional drawdown of federal money to support our Medicaid program. That was going to expire this year. And thankfully, the General Assembly agreed that this was something that we didn't have the resources to fill that hole without that kind of provider fee. The hospital community was supportive of doing it because they realized that that was essential for them, and they all were in favor of continuing this. And so we are fortunate we filled that, I think, and I think it was a good resolution of it. We delegated the authority to the Department of Community Health and the board there to fix that fee. It is also delegated to them in previous years for the nursing home industry, and that's been in place, I think, since 2004. So it's not a total departure from the protocol there. But that being said, even with that, with the onset of the provisions of the Affordable Care Act, the President calls it Obamacare, so I guess I'm entitled to call it that too, but it is the Affordable Care Act. That was a piece of legislation that passed in 2010 and had staggered implementation provisions in it. The biggest portion of the implementation will take place in 2014. But there are things that have already come into play even before that. What we are seeing is, as a result of that, which has an individual mandate in it, that is, that an individual in 2014 will have to show that they are insured. If they are not insured, they will have to pay a penalty. Employers, if they have 50 or more employees, will be under sanctions to provide health insurance coverage. And as you may know, that's where the vast majority of individuals get their health insurance, is through a group plan provided by their employer. But as all of these things begin to coalesce toward 2014, we are seeing that even though we have not elected to expand the Medicaid eligible population, that is the definition of who is Medicaid eligible, to expand that definition up to a higher percentage of the federal rate of poverty. We are still seeing cost with an expansion of our program, even as it is now. In fact, we are told that we will probably see about 100,000 people come into our Medicaid rolls, even if we choose not to expand. And the reason is this: we have a lot of folks who are technically eligible now, but are not enrolled in Medicaid. As the mandate comes down for them to show they're insured, well, if they're eligible for a government program, that's obviously where they're going to go and sign up. It's going to cost us, just by that, the technical term I'm told is woodworking effect, people that are out there eligible but not enrolled. As they come into the program, those 100,000, just with our current program, it's anticipated it will cost us $1.7 billion over the next 10 years to accommodate them. If we choose, or had we chosen, to expand the Medicaid enrollment eligibility, it would have projected to have cost us about $4.5 billion over the next 10 years for that expansion. So it is a dollar and cents issue. It is one that we think it's important that we maintain solvency, not only in Medicaid programs, but obviously we're mandated by the Constitution to maintain solvency of the state budget itself, and it's a big part of the state budget. Well, that's just a little fast overview. I'll be glad to take any questions that you might have. Yes.
Do you believe that the cost of the uninsured, when they go to the ER to get care, do you believe that that also puts a demand on the budget, that maybe if Medicaid was expanded, it would offset that ER cost for the uninsured?
Well, that's a good argument, obviously. The point, though, is in terms of direct cost, no, to the state. We don't provide supplements to those ERs. Now, those costs are either absorbed within the operating cost of the hospital, and most would argue they are passed along to the paying patients who currently have outside insurance, and therefore it's reflected in their premiums. When I was a member of Congress, which I was a member of Congress for about 17 years before I came here, one of the things I tried to get done, and actually got it done in the U.S. House of Representatives in 2006, I guess it was, couldn't get it passed in the Senate, was to do this. Part of the reason that we're seeing folks show up at our ERs is not because they are true emergencies. It's just because that's their medical home, you know? I got a provision passed that said that if someone presents themselves at an ER and it's not an emergency, by definition, it's not an emergency, that the ER physician and staff could refer those individuals to another setting, doctor's office, clinic, within a certain, it had to be within like 1.5 miles of the ER. Only way you're going to get that to work, though, is what? Well, no, those folks that are making that deferral decision are going to have some protection from being sued. They're not going to make that decision because they're not always going to be 100% right. You know, it may not look like an emergency, but it may turn out to have been an emergency. Was that you had to have some liability protection for that ER staff making that deferral decision. Like I say, we got it passed in the House, never could get the Senate to take it up. There are a lot of mechanisms we could have. If we could give emergency room physicians and their staff some degree of liability to defer people to a lower cost setting, part of that would be help. But we can't do it at the state level because there's a federal statute called EMTALA. Probably you've all heard about it. It came out of some really, really bad circumstances many years ago where women who were in labor were presenting themselves to hospitals and emergency rooms, and they were asked, do you have any insurance? And they said no, and they were turned away, and bad things happened. The federal government came back in and passed federal statute that said if you present yourself to an emergency room, you must be treated. Doesn't say it has to be an emergency, just that you must be treated. So unless you get some federal action to waive some of those things, we can't take the pressure off of the emergency rooms.